SATs leak, all of those things are going to be sort of factors in your head of like, how do we keep this kid safe until we get them out of the house? As far as alarm parameters go, these are going to be sort of similar to what you guys are used to in the adult setting. So we have that pressure limit. You also have another pressure limit here. So the pressure limit on the control side was 30. On this side, it's going to be 40. So you're never going to actually hit this pressure limit. The ventilator is going to cycle out before that. So you can keep it at 40. You can put it at 30 to match it if you want. It really doesn't matter that much. As far as minute ventilation goes, this is patient specific. Again, if you have a patient who has a decent sized leak, and we will have this in our NICU, we'll have kids that have these like fairly prominent leaks, and we'll put our low minute volume to 0 or to 0.02. I don't recommend that here, but I would say keep in mind the size of your patient, and if your tidal volume is a smaller volume, say it's like 20, you're not going to need to have a super high exhale minute ventilation as far as an alarm goes. So keep your parameters somewhat relevant, but you also don't want to have alarm fatigue, especially in your ER with people getting fired up already. Again, so say that you were having a return minute ventilation of, say return minute ventilation was 2, I would set my low parameter for 1, my high parameter for 4 is kind of 2 apart, you know, so it doesn't have to be something super specific. Your respiratory rate, depending on whatever's happening with the child. Some kids in respiratory distress are going to breathe very quickly, especially younger children. Some neonates, especially ones that have just left the hospital, say they're 1 or 2 months old, they may have a respiratory rate that is up in the 60s and 70s. And so if they're in a condition where they're ill and they're trying to kind of work harder, you may set your high respiratory rate alarm to like 90 or 100. It could be a higher alarm. And again, you're keeping in mind that the function of their illness is having them breathe like that. We're not happy with that respiratory rate. We're going to try to do what we can to reduce that, but we are accepting of it and saying, hey, we want to make our alarm parameters be reasonable. And then low respiratory rate, you're going to be eyes on this patient the entire time. So you can set your low respiratory rate at whatever you'd like. I would say, you know, maybe 10, 20, but you're going to be eyes on the patient. It's probably not going to be super relevant for you to have a low respiratory rate alarm. Tidal volume is sort of similar. You're going to go 5-10 mils per kilo above where you were set. And then apnea time is set at 5, but you're not going to let this patient go apneic anyways, right? So you're going to be there, you're not going to let this happen. It would be relevant if you were to be leaving the patient in the ventilator, but since that is not going to happen, you don't have to worry about that. I would just keep it set at the 5 that it has. And you can go up on that if the patient is if they are sort of having some apneas, you can go up to like say 20 or 30, but I don't think you're going to have to do that. All right, so to recap, you're going to use volume, you're going to use SIMV, you're going to use 6 to 8 mLs per kilo, PEEP of 5 to 8, pressure support 5 to 10, FiO2 to get the SATs that you want, eye time of 0.4 to 0.5 for a neonate, 0.6 to 0.7 for a pediatric patient, and then a respiratory rate of 20 to 40. I think I covered all of that.